Hi, this is Clyde Yancy. I'm Chief of Cardiology at Northwestern University, Feinberg School of Medicine, and Associate Director of the Bloom Cardiovascular Institute. I have the privilege of directing our 8th annual Cardiovascular Diseases Update, and I've had the opportunity to engage with some of our speakers who are bringing really brilliant content about state-of-the-art issues that affect all of us that think about and practice cardiovascular medicine. It's a real joy to welcome Jonathan Piccini with us. He actually is an alum of Northwestern, now at Duke, one of my favorite other medical centers. But we've had really a very similar thought process about two very important conditions. And over the next several minutes, Jonathan and I will talk about heart failure and atrial fibrillation, how they intersect, why they co-occur, and then this new dynamic that we're evolving of looking at the patient with heart failure uniquely as a candidate for the most aggressive treatment for atrial fibrillation. So Jonathan, delighted to have you here, and we and the audience are really interested in your perspectives about heart failure, and then I'll say my perspectives about atrial fibrillation. The qualification is that Jonathan's an unbelievably talented electrophysiologist.
Well, it's great to be back, and it's great to have the chance to talk about atrial fibrillation and heart failure. For us as electrophysiologists, the occurrence of heart failure is very concerning across multiple heart rhythm disorders. But in patients with atrial fibrillation who develop heart failure, we know that their risk for adverse cardiovascular events and even mortality goes up several fold once the condition is present. And there's fortunately lots of great treatments for patients with atrial fibrillation or heart failure. One area where we fall short is preventing the development of heart failure. And so I think all of those things are a concern. And fortunately, through several clinical trials over the past 5 years, we've learned a lot that we haven't appreciated before.
And so when I think about atrial fibrillation from my lens of heart failure, I see a condition that greatly exacerbates the clinical care of my patients. And so the worsening of symptoms, the refractoriness of responsiveness to evidence-based therapy, it really does amp up our anxieties, but worse than that, it really generates a worse prognosis for our patients. And so I go into this saying, okay, this is a new target because I'm thinking about how can I make the heart failure better, and atrial fibrillation really gives us a challenge. You correctly highlighted that we've had several recent data sets that help us. Let's start with the most basic thing. Sinus rhythm or atrial fibrillation with rate control. What are your thoughts as an electrophysiologist?
Yes, so in AFib, one of the things we always focus on is asking, is the atrial fibrillation symptomatic? Does the patient feel unwell when they're not in sinus rhythm? And for a lot of us, we would argue that in the presence of heart failure, there's really no such thing as asymptomatic atrial fibrillation because we know that
it's making it worse.
It's making it worse. So I think in the past, clinical trials like the CHF trial, which compared medical rhythm control with antiarrhythmic drugs versus rate control, failed to identify a difference between the therapies. One was not superior to the other. And a large part of that is probably the tools we had to keep people in normal rhythm weren't great. Medications like amiodarone that we know often have toxicities.
And that was so frustrating, right? Because as a physiologist, you have to believe that sinus rhythm makes a lot more sense hemodynamically than atrial fibrillation. But when the ventricle is intact and you control the rate response, it looks like that is okay. But when the ventricle isn't intact, it just worries us. Even if it, as you say, doesn't cause overt differences in symptoms, it progresses the biology, and that's really a concern. So if we think now about treating the atrial fibrillation vis-a-vis the contemporary approaches, what's been our track record trying to be more aggressive using ablation or using antiarrhythmic therapy to achieve sinus rhythm? Let's take the drugs first.
Yeah, so I think one of the most important things that highlights the importance of sinus rhythm and heart failure was this analysis by all the beta blocker trialists who pooled all their data together. And we all know that beta blockers are transformative medications for patients with heart failure, but when they looked at the data of how effective beta blockers were in clinical trials in patients who were in atrial fibrillation at the start of the trial, they couldn't identify any mortality benefit or any reduction in hospitalization. So again, highlighting the importance of sinus rhythm. And if we try to use antiarrhythmic medications, we know that the guidelines, based upon the risks in heart failure, the only two that are guideline endorsed for the treatment of patients with AFib and heart failure are dofetilide, which we know we can't use in patients with advanced chronic kidney disease or even moderate chronic kidney disease.
Right.
And amiodarone, which we know has a lot of toxicities and challenges. So there's not a lot of options.
I mean, have you ever listened to yourself when you tell a patient about all the potential things that can happen with amiodarone? It's a little bit disquieting, right?
Yes, or the patient will say, well, doc, what would you do?
Yeah.
And that can also be a little bit awkward because, the labels for the medications are very, very frightening.
But the big point to talk about then is what's the role of ablation when we think about this intersection of atrial fibrillation and heart failure?
Yeah, so I think the cornerstone of catheter ablation of atrial fibrillation in all patients really is the presence of symptoms that defy medical therapy. And I think that's true in heart failure as well. But we've gotten recent evidence that in patients who have a low ejection fraction, heart failure with reduced ejection fraction, there may be benefits in hard cardiovascular outcomes, potentially reductions in mortality, potentially reductions in heart failure hospitalization. There's been not one, not two, not three, there's been many clinical trials now, and each has limitations, but when you put all of them together, the data speaks pretty consistently.
Yeah. The one data point that is irrefutable, which I really think is a take-home message, is in the very large Cabana trial. When investigators at Duke evaluated quality of life, that was incontrovertible. Quality of life was clearly better, arguing that if patients can go through a procedure that leads to sinus rhythm, maybe, and I agree with you, maybe the heart outcomes are better, but at least the patient feels better. Has that been your clinical experience?
That has been my clinical experience, and I think most. There are those frustrating patients who have class 4 diastolic dysfunction and an ejection fraction of 10%, who we know are going to have a really difficult time staying in sinus rhythm because they have severe left atrial enlargement. But in appropriately selected patients, you will often see significant improvement in their functional status, minimization of hospitalization, and all those other outcomes that we've observed in clinical studies.
I'd be remiss in my role as a heart failure doctor if I didn't emphasize that just having heart failure gets your CHAS-FAST-2 score at the threshold where you need anticoagulation for stroke reduction. So as we kind of wrap this up, give the audience 2 or 3 pearls when they're thinking about the patient in front of them that has both atrial fibrillation and heart failure. What are those 2 or 3 pearls?
So and not to be contradictory, I would suggest that it's very important for that patient to be rate controlled when they're in atrial fibrillation. So just because the mortality benefit or hospitalization reduction with beta blockers may not be as large of a benefit as patients in sinus rhythm, they're still very important medications. We need to be very aggressive about stroke reduction therapy. As you point out, all those patients need oral anticoagulation. And for patients who continue to have symptoms or clinicians thinking about an antiarrhythmic drug, I think those patients should be evaluated for ablation. Not all of them will be appropriate, but at least should be brought into the discussion and thought about carefully on a patient-by-patient basis.
And Jonathan, all I'm going to do is endorse what I think are these 3 incredibly important points you made. Stabilize the patient with rate control, recognize the risk for stroke, start anticoagulation, and then in a shared decision-making model, looking at clinical trial data, understand that some, but not all patients, may be candidates for AF ablation, and perhaps there'll be some improvement in clinical outcomes, but more confidently, there likely will be improvement in quality of life.
I think that's very well said.
An electrophysiologist and a heart failure doctor seeing eye to eye. That's a good thing. What a pleasure to talk to you. I hope this has been informative because these are ubiquitous cardiovascular diseases, and we've really tried to give you some clarity about how you can understand this intersection and think about what you do next when you see these patients. Thanks very much for your attention.